Hello, and welcome to Quick Look Cardiac Electrical Mechanical Function. This is not meant to be the end-all and be-all of EKG monitoring, but it is important for us to correlate our signals to the mechanical response so we can best understand how our patients can stay alive while under our care when they have critical issues with perfusion. And so, to begin, it's always important to remember that you must have electrical events to actually achieve mechanical events. What does that mean? I must have depolarization to have contraction. Now, I can have electrical depolarization without mechanical contraction. That's what PEA is, pulseless electrical activity. But we can never have a mechanical response if we are asystolic, or if our electrical activity is very chaotic and out of control, such as VTAC or VFib. The electrical event of depolarization is what frees ionized calcium to move into the muscle cells or the myocytes in order to promote contraction. And removal of ionized calcium allows for mechanical relaxation. So, first, just a reminder about electrical, and we're going to look at it a little bit more in depth, but to remind ourselves that we have a series of highly potential bodies that reside in the heart, first at the sinus node, then at the AV junction, just below the AV junction, which is the bundle of His, which then bifurcates into the right and left bundle branches, and that terminates in Purkinje fibers. So all of that list, that is your rapid electrical highway responsible for distributing impulse into the chambers. So, first we think about our sinus node. The sinus node fires and it transmits impulses throughout the atria. Now that transmission of impulse throughout the atria actually gives us the picture on EKG of the P wave. That impulse that's transmitted throughout the atria frees the ionized calcium so the atria can contract. And the impulse is gathered in the AV junction and delayed there. The delay in the AV junction, which then transfers the impulse down to what we call the common bundle or the bundle of His, that period of electrical delay is what allows time for the atria to contract. And of course, that's quite important because when the atria contracts, it optimizes the filling of your ventricles. The delay time in the AV node, the AV bundle into the common bundle of His, is known as the PR segment. Most of us don't measure the PR segment. We measure from the beginning of the P to the end of the PR segment, and we call it the PR interval. That impulse now is spread rapidly into the right and left bundle branches, into the large muscle mass of the left ventricle, and into the small muscle mass of the right ventricle. And that is a very high level of rapid delivery of electrical stimulation, which then gives us the visual of the QRS, or the waveforms associated with ventricular depolarization. So again, sinus node into the atria, atrial contraction, captured in the AV junction, into the common bundle of His, delivered into the ventricles, ventricular contraction. Very important to appreciate that standard electrical activation will give your best opportunity for standard atrial contraction and ventricular contraction. AV, AV, AV. Standardized electrical depolarization gives us our best chance. So, the electrical conduction system, which is heralded by the EKG waveform, and again, is a review for most of you, one complete cycle, P, QRS, and T. So the P wave signifying atrial depolarization, which then is followed by the mechanical atrial contraction, which you can't see. We actually do have atrial repolarization, but you can't see it because it's swallowed up by the voltage and the beauty of your QRS complex. The QRS complex is ventricular depolarization, which is also followed by ventricular contraction. And remember, atrial repolarization happened within that. You just don't see it. The QRS complex is followed by the T wave. The T wave indicates ventricular repolarization. So all of this is about ionic shifts. And the most important ionic shift is in the atria is the influx of potassium and calcium into the atrial cells, which creates current. And that allows calcium to be released for contraction. And in the ventricles, potassium and sodium, which release current. And that allows for calcium to influx into the ventricular cells to allow contraction. So electrically, the atria are dependent on potassium and calcium. The ventricle is dependent on potassium and sodium, and all contraction is dependent on calcium. So if we just take this last quick look, oh so farewell to our EKG, we see the P wave, which is the depolarization of the atria in response to the sinus node triggering it. The PR interval, which is that nice delay time that allows the atria to contract and fill the ventricles. The QRS, which is the depolarization of the ventricles, and that is what is triggering that main pump for the calcium to be moved into the myocyte for contraction. And the ST segment is the beginning, and really it's a stable period of time of electrical current. And then the T wave, which is the shift of current for ventricular repolarization. Now, this was a very fast explanation. My assumption is that most of you have taken basic EKG, and if you want more information, I refer you to other forms of EKG training, lots of which I offer here at Grady. All right, so this is our typical EKG readout. What you're seeing here is leads 1, 2, and 3 on a 12-lead EKG, but really I put this here so you can just look at P, QRS, ST, and T. So this is a very beautiful time, 2 intervals, PR interval and ST segment, which is an interval. And we're looking at the QRS, the P wave, the QRS, and the T wave. All of those, P wave, QRS, and T wave, are about changes in current. The PR segment, the ST segment, are about stable current. And those are really important concepts when we think of our EKG. Okay, so on our EKG readout, this is what each represents. P wave, atrial depolarization, QRS, ventricular depolarization, T wave, ventricular repolarization. And the key to success when we're evaluating patients and their EKGs is to always have a systematic approach. To look at the patient's heart rate and the patient's rhythm, to look at P to P to P to P and make sure that that interval from first P to second P to third P to 4P is always constant. To look at the PR interval from the beginning of the P wave to the QRS and making sure that is always constant. And then, by the way, making sure every P and PR is followed by a QRS. And that the QRS, QRS1 to QRS2 to QRS3, is always constant. So if you just make a small mark on an index card where the first P is and the second P is, and march that along your EKG, and then match that to your QRS, and march along your EKG, you'll be able to actually discover the systematic approach and whether or not your patient has a regular rate and a regular rhythm. It is important to remember that the normal PR interval from the beginning of the P wave to the onset of the QRS normally is 3 small to 5 small boxes. So 0.12, those are 3 small, to 5 small, 0.20. Those are all time measures. and that the QRS interval is normally less than 2.5 small boxes, 0.10. Again, I'm not necessarily explaining these basics because I'm quite certain you already know them. All right, so rules for normal cardiac rhythm. Every P should have a QRS. P to P should equal R to R, or QRS to QRS. PR interval should be constant, and the overall heart rate should be between 60 and 100 per minute. All impulses should originate from the sinus node, and you know they're from the sinus node because they are firing at a rate of 60 to 100. Remember, the P wave is about the activation of the atria. That impulse should be conducted through the normal conduction pathway. That means to the AV junction, common bundle, and right and left bundle branches. And you know it's normal if the width of the QRS is less than 0.10. If it's wider than 0.10, that is not normal. So that impulse passing through those conducting pathways with normal regularity and a normal velocity give us significant information. Time, meaning the time counting your small boxes across, and voltage, meaning counting your boxes up or down, is absolutely necessary for electrical and mechanical to meet. Now, what does that mean? It means you have to have enough time after activation for mechanical response to occur. And you have to have enough stimulus for the chambers to actually respond to depolarization. So I have to have a good voltage in my ventricles to reach all those tissue and promote depolarization and therefore contraction. Now, many factors influence heart rate. Certainly, we know that chemicals, endogenous chemicals, I've released internally epinephrine and norepinephrine, or you're giving me externally epinephrine and norepinephrine. Those are chemical regulations that are going to affect my heart rate. If I have loss of myocardial function, that's going to significantly impact my heart rate because the heart rate will go up to compensate for the loss of the cardiac function. Hormones can profoundly affect your heart rate, and the most important hormone that affects your heart rate is the thyroid hormone. Sometimes people forget that profound link between thyroid hormone and myocardial function, in this instance talking about heart rate. If I'm hyperthyroid, I will be tachycardic. If I'm hypothyroid, I can be bradycardic. So that's very important when we're considering this for our patients. And last but not least are electrolytes. If you recall, I mentioned before that your atrial tissue is dependent on the influx of potassium and calcium, and then the release of calcium for contraction. That means abnormalities in potassium or calcium can affect atrial conduction. And the ventricles are dependent on the influx of potassium and sodium for depolarization, and calcium for contraction. So abnormalities in potassium are going to affect both the atria and the ventricle, delaying or significantly altering the conduction, time, and velocity of depolarization. Now that might be a little more than you were ready to hear, and that's okay, because we're going to talk more and more about this, and we're just going to build and build and build on that fabulous knowledge you already have. But I just want to remind you never to forget the role of electrolytes in the cardiac depolarization and contraction, and that atrial tissue are potassium and calcium dependent, ventricular tissue are potassium and sodium dependent, which means in either disorder, you always can safely give a potassium channel antagonist. And by the way, that's amiodarone. That's why we use it. Pretty fabulous, eh? All right, now, we also want to remind ourselves that the nervous system controls the heart rate. Sympathetic nervous system stimulation, actually utilizing catecholamines, epinephrine and norepinephrine, will make the heart rate go up and make the contraction of the ventricles and atria stronger. Also, should elicit a vasoconstrictive response in your vessels. The parasympathetic nervous system, mediated by the hormone or by the transmitter, mediated by the transmitter, acetylcholine, actually makes the heart rate go down and reduces the high level contraction and can also promote vasodilation. So they're in direct opposition to each other, and in normal situation, they're in complete balance. But we frequently will see that we're very sympathetically heavy in critical illness with tachycardia, hypercontractility, vasoconstriction, venoconstriction. So very important for us to consider that whenever we come to the bedside and as we're giving patients exogenous catecholamines, norepinephrine and epinephrine, and what that does to cause the response. So our salient points so far are: we would like to always have normal electrical activation. That's the rate, depolarization, and repolarization that leads to the normal ejection, contraction, and relaxation, filling of both atria and ventricles. And always remember the three big deals that will increase your heart rate: your endogenous or exogenous catecholamines, epinephrine and norepinephrine, and tissue-level hypoxia, which profoundly affects the heart rate. But the problem is, the faster the heart is beating, the less time the ventricles have to fill. So as the heart rate goes up, the ventricular filling and therefore ejection goes down. Now, persistent tachycardia is always a cause for concern. I'm always going to have a discussion. A lot of times when I have a discussion, my provider will say, well, that's just compensatory. Yes, of course, thank you so much. But compensatory for what is what I really want to know. Is my patient agitated? Does he have pain? Is he hypoxic? Let me try to fix the problem that he's compensating for. So I'm always concerned about persistent tachycardia. Okay, so when we're monitoring and we see a patient who's tachycardic, we're going to consider, number one, that they're compensatory for a low amount of volume that the heart is ejecting. That's the stroke volume, the amount of volume the heart ejects per beat. And that often is a clue to a patient who is hypovolemic, hemorrhagic, who has cardiac failure, or who has an alteration, most particularly vasodilation in their vascular tone. So again, when I see tachycardia, I want to know why my patient is tachycardic. Are they hypovolemic? Are they hemorrhaging? Do they have a failing heart? Do they have an alteration in their vascular tone? I want the answer to all those questions. I need the answer to all those questions. And another thing that I'll look at is I'll look at their chemistry profile to look at their total serum CO2 and their anion gap, or I can also look at their arterial blood gas, even if I'm not an expert. All I have to look at on the arterial blood gas is, do they have a base deficit? Now remember what base deficit is. Base deficit looks at all the circulating buffers that bind up acid. So when the base goes into deficit, the acid is always in excess. And that's a metabolic acid, that's hydrogen ion. Base in deficit, metabolic acid in excess. If I have metabolic acid in excess, I've got a problem. And I have to uncover what that is. It is possible that that could be a compensation, but I always want to investigate it as a possibility of a problem before I consider that it's compensatory. And again, we're going to talk a lot more about blood gases in a hopefully very simplified way to help us understand and apply that at the bedside. In addition, on the chemistry profile, I can look for hyperglycemia. If my patient is hyperglycemia, I might consider that they have ketosis. And when you are breaking down non-glucose products, particularly fats, to make glucose, you yield ketones. So patients who are ketotic will actually be expressing metabolic acidosis. And of course, last but not least, very importantly, is the presence of lactic acid. And we see lactic acid elevate in patients who have many conditions, but what we use it for most significantly is to tell us that our patient is hypoperfused. I want to monitor the heart rate. I'm going to go back to that and say, when you have tachycardia, there's always a secondary reason. They're not just this list. There's many reasons for you to have tachycardia. Your job is to figure out why and not to allow it to persist without understanding why it's present. Okay, so salient points so far: Persistent tachycardia is always a warning sign. Pay attention. Investigate whether it's pain, agitation, high fever, or is it compensatory for tissue hypoxia, such as it is with hypovolemic shock, such as it is with hemorrhagic shock, such as it is with septic shock. Always investigate rapid heart rate. And remember that the faster the heart beats, the more it reduces the time of rest for the myocardium, and resting time, repolarization, and relaxation is when the ventricle fills with volume. So persistent tachycardia, by the way, is always a cause for concern. Okay, so that brings us really to the mechanics that are correlated to the electrical activity. So we remember the electrical activity of the atria is the P wave, and that actually promotes atrial systole. Electrical activation of the atria, the P wave, promotes atrial contraction. Now the atria contracts when the AV valves are open, and the atria contracts to optimize, actively fill the ventricle. So as we see that P wave, we expect atrial contraction, which will optimize the filling of the ventricle. Now those AV valves have been open for a second, so some volume moves from the atria to the ventricle. Just write down a gradient of pressure, because the pressure in the atria higher than the pressure in the ventricle at that time. But that last squeeze requires a P wave. Then we have atrial diastole. That would be following the atrial repolarization wave that you never see. The AV valves are shut, the atria is relaxed, and the atria is now filling from the veins. You don't see it electrically. The only thing you ever see is the P wave. That's all you see to tell you about what's happening in the atria. So the P wave, remember, stimulates atrial contraction. Atria contracts through the AV valve closes. Now the atria relaxes and fills with blood from the vein. Now, the atria is filling the ventricle during diastole. So go to the bottom of that column for ventricular diastole. Okay? The semilunar valves, aortic and pulmonic, are closed. The ventricle is relaxing, 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 and blood is filling from the atria. First of all, passively down a gradient, and then actively following the atrial contraction. So our ventricle gets mighty full from the atria as long as we have adequate volume and our valves don't stand in the way. Valves stand in the way when they're stenotic. Valves stand in the way when they're regurgitant. But if we have good valves and normal volume, the atria will maximize the filling of the ventricle as long as there is time for your ventricles to fill. Now, after the ventricles have filled, activation of the ventricle occurs. That's the ventricular activation seen as the QRS. And now the ventricle starts to contract. And it contracts and contracts and contracts until that semilunar valve opens up and blood shoots out into the arteries. The aorta for the left heart, the pulmonary artery for the right heart. So what's really important here is to appreciate electrical, mechanical, atrial, ventricular, and valves. All of this is important in the optimizing of what you care about at the end, which is, does my ventricle eject adequate blood? That blood will deliver oxygen to the tissues, deliver CO2 to the lungs. That blood flow is quintessential to survival and to maintaining organ function. So we always want to remind ourselves that the way we talk about this is cardiac output. Cardiac output is heart rate times stroke volume. Now, stroke volume is the amount of blood ejected by the heart per beat. The patient can manipulate this to a point because he can increase his heart rate via sympathetic stimulation, and remember, that's always compensatory. He can also increase his myocardial contractility related to sympathetic stimulation, but only to a point. We as providers, however, take over control, because we want to increase that cardiac output by increasing the stroke volume and the inotropic function. Now, why is this important? Because when you're in the ICU, you have many opportunities to actually evaluate cardiac output. But I want you to remember cardiac output has two components, heart rate and stroke volume. Heart rate is how fast your heart is beating. Stroke volume is the amount of volume ejected by the heart per beat. So as a provider, my focus will always be to increase the stroke volume and allow the heart rate to come down. Stroke volume improvement typically is determined by two things, ventricular volume and ventricular contractility. So I, as a provider, may give that patient volume to increase their ventricular volume, and I may give them myocardial contractile agents to improve their myocardial contraction. That's known as inotrope. And it's always important to remember that this is despite presence of hypoperfusion. You can have significant and profound hypoperfusion and still have a relatively normal blood pressure. So that's why blood pressure is not the end-all and be-all, although we're going to pay so much attention to it. It's not the end-all and be-all of everything we need to understand and manipulate when we're talking about critical patients. Now, cardiac output is the amount of blood ejected by the ventricle in 1 minute. That's why it's heart rate times stroke volume. Stroke volume is a beat-to-beat measure. Heart rate is a minute measure. Heart rate times stroke volume gives you cardiac output. And typically, normal cardiac output is 4 to 6 liters per minute. So vasodilation or increased tissue demand may actually result in a cardiac output that goes up to 21 liters per minute. You'll see patients in the liver unit at Emory with a cardiac output of 21 liters per minute because they're so hyperdynamic and they have so much volume and they have an effective heart. But for the most of us, we typically do not see cardiac output greater than about 12, and patients can't survive a cardiac output that's less than 2. So it's really important for us to remember we've got an average and it's 4 to 6 liters per minute. That's what we're going to strive for. But a normal cardiac output is the one that answers the tissue call for oxygen. So the ability to increase blood flow is a saving grace. And the inability to increase blood flow if my tissues need it is a predictor of problems. So I need to be very aware of cardiac output in whatever way I can be, depending on where I'm working, what I'm using. I'm going to use a lot of different tools to give me an idea about what my patient's stroke volume is and therefore their cardiac output. Okay, so first and foremost, we talk about ejection fraction. Ejection fraction is the percent of the volume that filled the ventricle that is ejected. It's a very straightforward thing, a very basic parameter. We use echocardiogram to tell us about ejection fraction. So we can order an echocardiogram, we can evaluate this with our echocardiogram, and the basic parameters is the amount of volume at the end of filling, known as end diastolic volume, minus the amount of volume at the end of ejection, and systolic volume, so EDV minus ESV, and then we divide that by the amount of filling. So you can see here in my simple way, I wrote amount ejected divided by amount of filling. Now we know that normal ejection fraction is 50 to 75%, okay? In individuals who have decreased myocardial contractility, their ejection fraction falls, okay? If what you have is hypovolemia, you still have the same ejection fraction, you just don't have enough volume. But if you have loss of myocardium, even small amounts of volume are not ejected effectively. So we always say decreased ejection fraction means that you have decreased contractility and you may also have significant valvular disease. Valvular disease we're going to repair with surgery. Decreased contractility we're going to pay a lot of attention to. And you might get an inotrope, you might get oral inotrope digitalis, you might get intravenous inotrope, dobutamine or milrinone, and if it's really bad, you might actually get an Impella. And that's a device that unloads your heart because you have no capability to contract your myocardium and eject volume. Increased ejection fraction, so high to the 75 or perhaps even above, 75 to 80% of what filled the ventricle is ejected outwards, can occur when we have very significant buildup in the muscle wall, known as hypertrophic cardiomyopathy. Can also occur when we have hyperthyroidism, and it can occur an increasing contractility in response to tissue demand for oxygen. So here's the thing. Any myocardium that is functional will maintain its ejection fraction along a line. It's linear. That stroke volume will be linear in relationship to the ejection fraction. More volume, less volume, same ejection fraction. Any myocardium which is functional will increase its stroke volume and its ejection fraction when tissues demand more oxygen. So, why do we care about stroke volume? Stroke volume, unlike percent ejected, stroke volume is amount ejected. So stroke volume is end diastolic volume, the volume that filled the ventricle, minus end systolic volume, the amount of volume left at the end of ejection. And normally, that's around 60 to 100 mLs, and we'll see that in a little bit. So you can see I had 120 filling my ventricle, 50 left after contraction. That means my stroke volume was 70. Now, we can measure that with an echocardiogram, but we can assume it or measure it in a wide variety of ways that you're going to come across in critical care. All right. So I just want to remind you about those factors that affect your stroke volume. One of them is called preload, and that is your end diastolic volume. That's the amount of volume that fills your ventricle at the end of diastole. And we don't talk about it as a volume measure, we talk about it as a pressure measure. So the pressure in the ventricle at the end of filling is what we call preload. That volume that filled the ventricle promotes ventricular stretch, which then allows for a better ventricular ejection. In general, if your heart is normal, I can give you a lot of volume, and that's not going to cause a problem because you have good contractility. But in a heart that's abnormal, if I give you volume, you're going to have worsening heart failure. Got to have a good contractile myocardium to accept the volume into it and to eject the volume out. Ejecting the volume out is the end systolic volume. Now that's totally dependent on how much volume and pressure was encouraged when I filled the ventricle, and it's also absolutely essentially dependent on the contractile mechanism of the myocardium. Now that contractile mechanism in the myocardium is completely independent from anything else. It's just, are your fibers alive and do they have calcium? That's all that is, the contractility. But then we have something else as well, and that is the amount of tension, not just contraction, but tension that that ventricle must generate in order to eject the volume out into the arteries. So that's known as afterload. So we talk about stroke volume as being affected by preload, contractility, and afterload. Those three things. Oops. And we'll talk about them more a little bit later. All right, very good. Normal stroke volume. Normal stroke volume. So easy because it correlates with a normal sinus rhythm. 60 to 100 mLs per beat. You can max up to about 200 mils per beat depending on your size, your heredity, your conditioning, and the tissue demands for oxygen. Stroke volume is the amount of blood that's ejected on each systolic ejection. Normal is 60 to 100. Now when we index that to your body surface area, which gives us a much better idea, much more clarity about the blood flow being delivered to your tissues, stroke index is normally 25 to 35 mLs to the meter square, which is the measure you make for stroke volume index. Okay, so basically that brings us back to desired effects of sympathetic stimulation. Sympathetic stimulation, endogenous, exogenous, epinephrine and norepinephrine. I have that myself and you give it to me. That increases the contractility of the myocardium. It increases the filling volume to a point because it causes venoconstriction, which returns blood back to the ventricles. It increases that filling volume, but the pressure measurement is variable. It's not always constant. So it increases my filling volume. it increases the contractility, and it also, by the way, not on that slide, increases your heart rate. Heart rate is up, ejection volume is up, cardiac output goes up. Now, I release my own norepinephrine and epinephrine because my tissues need more oxygen. You give me epinephrine and norepinephrine generally because you're trying to drive up my blood pressure. I want you to marry those two things together. I want to get your blood pressure up, but I also want to be sure I'm not making your tissues more hypoxic. And that's going to be really important in the management of the critically ill patient. And I want to remind you that heart rate is a pretty little liar. It's a pretty little liar, because when we see tachycardia, we say, hey, that's compensatory to increase your cardiac output because your tissues are hypoxic. And that is true until the heart rate goes up so much that I can't fill my ventricles. And that's why looking at cardiac output is not nearly as meaningful as looking at heart rate and stroke volume. So just remember, stroke volume is a combination of preload, which is the filling volume generating pressure, and how we're going to talk about that here is by monitoring central venous pressure, which is the preload volume and the right ventricular compliance. So, right, you have a stiff balloon, you put a little fluid in it, and the balloon is just like, it won't distend. And then I have a big, beautiful balloon. I put some volume in it, woo, and it distends. That's the difference, right? Preload volume is not preload pressure. Preload pressure is about the volume and the compliance of the chamber being filled. And the pressure I'm going to talk about here and in the next segment is about central venous pressure, which reflects the filling volume and the compliance of the right heart. Now, we treat that by giving you fluid, by giving you volume expanders, or if we think you have too much, we'll give you diuretics, vasodilators. We might even put you on CRT or ultrafiltrating volume like aquapheresis to mobilize volume out of your vessels and into a can, basically. Stroke volume, also affected by afterload. Afterload is the resistance to outflow, and that resistance to outflow creates a generation of tension of the ventricle. Now, we're going to look at afterload in our practice, in our general way, by following the mean arterial pressure, by following your systolic blood pressure, and by tracking your stroke volume. Okay, so now that's really important because in our attempts to raise your blood pressure, we may constrict your vessels so much that it's hard for your heart to eject volume and your stroke volume goes down. We're going to use vasoconstrictors or vasodilators to treat that resistance. We're going to cause more resistance with vasoconstrictors, and we're going to cause less resistance with vasodilators. And then we move to contractility. Contractility is the strength of the myocardial contraction, and we can only assume that by looking at your left ventricular stroke volume, that's in the arterial bed, or the cardiac output. And that tells us about whether you have functional contractile mechanism. If you have adequate preload, you have the right afterload, and you have a functionally contractile heart, you should have a very good stroke volume. You should have a very good cardiac output. And we treat contractility with inotropic medications, and by the way, ionized calcium, because remember, calcium is what makes you contract. Okay, very good. All right, so when I looked at my balanced components of heart rate to stroke volume, remember that stroke volume is affected by three things: the volume that fills the ventricle, the tension the ventricle has to develop to eject the volume, and the inherent contractile property of the myocardium. 1, 2, and 3, that all affects your stroke volume. When your heart rate goes up, that's an endogenous way to increase my cardiac output, but it's inefficient because as the heart rate goes up, the myocardium is using more oxygen, and now you start to limit the ability to fill the ventricle. That's why we're always concerned about persistent tachycardia. Okay? What our goal is to increase the stroke volume through manipulation of preload, afterload, and contractility. That is the efficient way for us to increase your cardiac output. And that's what we pay attention to when we use arterial blood pressure monitoring, when we use central venous pressure monitoring, and in the ICU in today's world where we can actually use your arterial pressure to actually calculate stroke volume and cardiac output, which is such an incredible tool that we have at our fingertips in our ICUs to help us actually evaluate our patients appropriately. So remember, follow that heart rate, tachycardia. Be aware that tachycardia of atrial or ventricular origin is going to reduce your stroke volume and therefore ultimately your cardiac output, particularly when the ventricular rate, the QRS, is greater than 130 to 150. That stroke volume reduction is due to decreased filling because of less time, and because there's reduced filling with less time, there's less volume for ejection. So always remember, tachyarrhythmia associated just with basic tachycardia or abnormal ventricular contraction will lead to reduced filling time, reduction in filling because there's not enough time, and therefore reduced ejection, and that will all contribute to less cardiac output. So if I'm evaluating a patient who has a rapid heart rate and increasing base deficit, which is metabolic acidosis, I already understand that they don't have an adequate stroke volume. I don't need special tools. Increasing tachycardia with worsening metabolic acidosis. I need to do something to help my patient get a better ventricular filling and a better ventricular ejection. Don't know what that is, have to talk, have to bring people to the bedside. Look, earlier today my patient's heart rate was 120 and his base deficit was -6. Now his heart rate's 150 and his base deficit's -10. Is he bleeding? Is he hypovolemic? Is he in cardiogenic shock? Is he septic? Is he in COVID shock? I don't know that until I look at all the data. And I need the team to do that with me. But the team needs to know that my patient's trend has been the heart rate's gone up and their metabolic acid's gone up. My team needs to know it. I need to point it out, and they're relying on me to have good eyes and good ears and good communication. Also watch out for new onset atrial fibrillation, because remember, at the end of ventricular filling, you got to have an atrial contraction. That's called the atrial kick. Well, when you're in atrial fib, you've lost that atrial kick. So normal hearts, that's about 10 to 20% of the ventricular volume. But if the heart is stiff, if I have a non-compliant ventricle, such as I might when I'm exercising, but also when I have heart failure, 40% of filling can be affected by the loss of atrial kick. So significantly reducing the volume in the ventricle and therefore reducing cardiac output. When patients have hypertrophic hearts and they have reduced compliance, that means their ventricle is stiff, that impairs the filling of the ventricle, the atria becomes overloaded with volume, the veins become overloaded with volume, either pulmonary veins or systemic veins or both. I've lost my atrial kick and now I've got venous engorgement. I have poor cardiac ejection and I have volume overload in my veins. Oftentimes, with acute onset atrial fibrillation, that really significantly and profoundly complicates the picture of your patient. So our salient points so far: must have electrical to maintain mechanical. You can have electrical depolarization without mechanical response, PEA. You can never have mechanical without electrical. The electrical event is what frees the ionized calcium to move into the cells for contraction, and that's what's going to affect ventricular ejection. And I want to remind you of a few more salient points. You must get volume into the ventricle for volume to come out of the ventricle. Always consider preload, volume in the ventricle, and the compliance of the ventricle. Afterload, resistance or tension to ventricular ejection, and contractility, the inherent property of the myocardium to contract, as long as there is free ionized calcium, which means you must have normal depolarization. Thank you very much.